All right, we're going to start tonight with the dental instrument of the day because I forgot to do it last week. So we're going to start with it right now. All right, so let me just get my screen to match yours. And those are fun little bubbles. All right. Almost there. Let's see. Okay. Or not. The suspense is killing me. I don't know about you. All right, why won't this? I have a beautiful view of the bubbles. Not. Let's see. Oh. I'll be right back. That's my tech issues. It's not, it's not the end. I don't know why. Okay. Where did I go wrong?
No, because your screensaver is up.
I know. It's strange.
Alright.
Okay, I've got a screensaver,
That's good.
but I don't have any of the things I try and show.
So that's good.
Yeah.
In. Try unplugging it.
I did that, but I will do it again.
Yeah, just
for
humor
your,
me.
I will, just for your fun.
No more.
Tried to do.
So you can see
It's
the mouse when you
on.
move it.
Oh, yeah.
How do you change it? I know. Okay, wait, let me try.
Oh,
Okay.
there it is.
So
Okay.
what it's doing is
Oh.
it's trying to make you, it's not doing a mirror, it's doing a duplicate.
Oh.
Or not a duplicate, it's doing a, this is one screen and that's another one.
Okay.
So you can drag, which one did you want them to see right now? If you take this, you can
Yep.
just kind of
Oh,
drag
like you
it
have
over
two
onto
computer
that
screens?
screen. And then can
Okay.
you use it from there? Is that okay?
Yeah.
Yeah?
Yeah. I should be able to.
And then you can always just, if you keep
Yeah.
going this way with the mouse,
So
it'll bring it back
okay.
to this main screen. So it thinks you have two screens going on
Okay.
right now.
So I just need to drag everything to the right.
Yeah,
Okay.
unless you can There's probably a way that you can switch it so you can have just one screen going.
Yeah, this was what I was
But-
trying to.
Very strange.
Very.
Yeah.
And counterintuitive, which is always my favorite thing to do while holding on to thoughts. Let's see. All right, so this doesn't. Okay. What about?
Is there like a settings or control panel that could work?
Okay.
Try that. Is there a displays?
Yeah.
That guy. Try connect to projector maybe. Go to duplicate instead of expand.
Much better. Thank you.
There we go.
There you go.
And then it.
Yeah, this should.
Cool.
Yep.
And there it is. All right. Sweet.
Thank you.
Awesome. No problem.
I was like, I am going to be screwed up for sure. Okay. So 8 minutes in and we're good. All right. So if you brought your instrument book with you, go ahead and open it up to, I believe it's the very first page. I have it up here on not that one, but this one. Ooh, that's very large. Okay. To basic dental instruments. And the first thing that we look at is the mouth mirror. So our first dental instrument is probably the one that is most familiar, the mouth mirror. You can pick one of these up at CVS. It is not made of the same material, of course, that would be used in the dental office because we typically don't sterilize them in the same way. But we've got this great mouth mirror here. There are a couple different styles, and some of them do reflect light from both sides. But the function of the mouth mirror is to retract the tissue, to provide indirect vision, to reflect light. Those are the main functions. And the most common is the front surface mirror, which is pictured at number 1. Our next instrument is the Dental Explorer, and the most common is pictured in the top row here. And let me just get rid of this. Okay, so this side is called the Right Angle Explorer. It is sometimes called it's mostly called the Right Angle Explorer. And then this side is the shepherd's hook. And they are typically combined on one instrument so that we can do most of the checking and examination. And this is a tactile instrument. And what that means is that the dentist will use it to feel the surfaces of the teeth. So, you know, when you're sitting in a dental chair and the dentist starts poking around, you know you're going to feel something. And what the dentist is doing with that is feeling. And so that's like, it's almost like reading Braille for a dentist, I guess, is that's how I tell what a tooth is like, is by using this that way. And so that is the most common. There are a couple others. This one's the Pigtail Explorer, and that is used mostly in periodontics. And if we remember from last week, periodontics is the study of what is around the tooth, right? So even if we don't know anything more than that, we can start to think about around the tooth by breaking down the word periodontic, and that will get us to around the tooth. And what's around the tooth? Gums and bone, or gingiva and bone. And then, let's see, the next is cotton plier, or as some dentists call it, the college plier. So cotton or college is used interchangeably for this. Sometimes it depends on where the dentist went to school. So if a doc says, I need the college plier, don't freak out, just hand him the cotton plier. And this is a pretty familiar instrument too, because it looks like tweezers, doesn't it? The difference is it's much longer so that we can get to areas in the back of the mouth. And this is used to grasp small items or to transfer materials in and out of the oral cavity. The tips of this instrument can either be plain or serrated. And you can see here, this is a serrated tip. So it's got little cross hatches in it. And that's what serrated is. And some of them lock and some of them don't. So this is a non-locking plier. If it were a locking plier, it would have an extra hinge here to keep the tips together while you're not holding it. So these three instruments together, hold on a second, are our basic instruments. And so this is a basic setup. Basic setups are on every tray for every procedure. So there are no procedures that don't need a mirror, explorer, and a cotton plier. So you will always have a basic set out. Now some offices package the basic together. So the mirror, explorer, cotton plier are in one either cassette like we see here. So this is an instrument cassette, or in one bag. And other offices include these as part of their larger setups. So it will depend on how they are stored, but almost every office has these three together separately because sometimes that's all you need is a basic setup to check the oral cavity. So our first exercise for our dental instrument of the day, what type of procedure is this tray setup used for? And we could say all of them. All right, so every procedure requires a basic setup. And name the instruments on this tray setup. And we would say mirror, explorer, cotton plier. And if this seems all pretty basic to you, trust me, it gets worse. All right, so that's your dental instrument of the day. On Evolve, there is an instrument test on these three instruments. And I would love to have you take it. It's not a required test, but I think the more you're exposed to the instruments, the better off it is. So you will also see that listed under week 2 when you go on to check your exams. And if you want to take it, feel free. Okay, and let's get to chapter 3. All right, so for most of the chapters, not all of them, I'm still working on some of them, but for most of the chapters, I have a review PowerPoint of the week before, which is sometimes a really good thing to do to sort of refresh yourself if it's been a while since you've watched the lecture and you're going to go take the test. So another way, rather than having to watch the whole lecture again if it's been a while, so let's say you go to take chapter 1 next week because keeps you away from it. Hey, I think do we have friends? Can't tell. I can't see any new ones. Oh yeah, yep. Hold on, let me just welcome at the risk of not sharing these. Okay. PBAC, I see you. And no one's there. Okay. Okay. So a good thing to do is to check the first PowerPoint of the week after the one you're working on to check the review. So there are some good exercises on there to get your mind jogged, some case studies, things like that. But I typically don't have time to run through them in class. So it's an extra if you want to do it. And we will look at where should I be. So hopefully everyone's taken chapter 1 and 2. I have not been on yet today because I've been working all day. But I did look last night and it looked like just about everybody, with the exception of a couple people, had been able to take chapters 1 and 2. So nice job. And I went on and corrected any answers. So if your grade went up, that's my fault. Yay. Right. It's always okay if the grade goes up. Okay, so what are our objectives in Chapter 3? Chapter 3 is anatomy and physiology. And our objectives are to pronounce, define, spell the key terms, which is always an objective for every chapter, to name and use the terms that describe direction in the body, and planes and sections, and then also organization levels, body systems and functions. This is all very basic that we're going to go into. Some of you come into this with a little bit of medical background, and you know more details than I'm going to give out. And that's because we are going to keep our most of our knowledge to the head and neck, if we can, because that's where we're focused. All right, so the head and neck will be our next task after we get our orientation in the body. And then we're going to identify the muscles and the nerves and the landmarks of the face and the oral cavity. So why do we spend time on anatomy and dental assisting? The short answer is because the mouth is part of the body as well. All right, so that's the short answer. Is that for a very long time,
Now I
so
okay.
yep. No, I just had to take an off break for 1 second. So for a very long time, the dentists were considered not doctors, basically. So how we could have doctors that specialize in the rest of the body and not doctors that specialize in the mouth doesn't really make a lot of sense. So making sure that we understand that things that happen in the mouth reflect on the whole body as well. So if your mouth is not healthy, your body is not healthy. These are the reasons why we spend a little bit of time with anatomy. The one thing that is probably most important about anatomy to us is that it will be on the RHS. So anatomy is on your radiation health and safety exam. So it's one of the main reasons why we want to master anatomy. And so anatomy is how the body is put together, and physiology is how it works. And we're going to stick mostly with anatomy and less with physiology, but we'll do a little bit. Okay, so body planes and directions. I think everybody has mastered the whole right and left thing, and so hopefully you have anyways. So the directions and body planes are opposites of each other typically. So you know, if you can describe one thing, you always want to describe the other. So we're going to start with the planes of the body. And planes are imaginary lines that divide the body into sections that make it easier for us to discuss. So the sagittal plane divides your body into right and left sides. A mid-sagittal is right down the middle so that your right side and left sides are equal. So sagittal and mid-sagittal are important concepts in dentistry because we talk about lining patients up by their mid-sagittal plane, which basically means that I want the very dead center of their face to be somewhere, okay? The next plane is the transverse plane, and the transverse divides us into superior and inferior, meaning top and bottom. This is sometimes called a cross-section. And then the frontal plane divides the body into front and back, or anterior and posterior. And this is sometimes called coronal. And we're going to look at these in a little bit more detail. There we go. Okay. So here we have someone looking in the mirror at themselves, and she says, my posterior sure looks fine. All right, so what are we talking about when we say posterior? We're talking about the back. And it's a good thing my horizontal plane isn't even. So typically, I guess if you want to see an even horizontal plane, you could look at me standing up. So my legs aren't much longer than the rest of me. So a horizontal plane being even means that the top and the bottom are equal. So your inferior and superior sections are equal. Okay, so anatomical position is how we look at the body when we're describing these different directions and planes. And so anatomic position is with the body facing forward with palms up. If you've ever been, and this is one of my favorite adventures of my life, I spent a couple years inside the gross anatomy lab as a dental student, and that is where they keep the bodies that you use for dissection for learning about the human body. So that was, there's like 30 or so bodies, or even more, I think, because we had a large class inside of this room. So you're just surrounded by corpses, but are facing up with their palms raised. So the rest of those directions that we look at are medial and lateral. So medial is near to the center of the body, and lateral is away from the center of the body. And then we have proximal and distal. Proximal is near to a point, and distal is away from a point. So medial, close to the midline of the body. Lateral, far away from the midline of the body. Proximal, close to a point. So if I say that my point is here, I can say that my elbow is proximal to my hand. It's near to. And then distal would be my wrist. My wrist is distal to where my hand is, so that's further away. Anterior and posterior, as we looked at already, anterior is front, posterior is back, and then superior and inferior. Superior is towards the top, inferior towards the bottom. So the organization levels of the body. The human body has 4 organizational levels, and these are cells, tissues, organs, and then organ systems. So we all start as a single cell, and there are trillions of microscopic cell factories. And I'm sure if you recall your high school days, the only thing you come out knowing, the mitochondria is the powerhouse of the cell, right? So they make you memorize these things. But when you get a bunch of cells together, then you have tissues. The 4 main types of tissues in the human body are connective, epithelial, muscle, and nerve. And all 4 of these tissues are found in the head and neck. So we will be looking at them in one way or another. Tissues then group together into organs that have a single specific function. And your organs are heart, your lungs, your brain, stomach, liver, intestine. And then an organ system, I just said that. Organ systems are organs that work together to function, carrying out one function or a single group of functions. So a body system is made up of organs, and organs may belong to more than one body system. And there are 11 major systems in the human body that we're going to look at. And so a couple highlights to the human body systems. So our cardiovascular system transports nutrients throughout the body, and this is made up of the heart and arteries and veins. The integumentary system is your skin, and this helps to regulate body temperature and is also a great barrier to infection, as we will see next week. And then another to look at is the musculoskeletal system, which are the bones and the muscles. And there are 3 types of muscles in the body. There are smooth muscles, which are the ones that we don't really think about. So they're the inside of our digestive tract. They do their thing without asking anybody, pretty much. So the striated muscles are the ones that do the work and help us to exercise. And then the cardiac muscle is your heart muscles. And you can find examples of all 11 systems in the head and neck. So the next structures that we're going to cover are the types of bone that make up the human skeleton, anatomy of the skull, the sinuses, the temporomandibular joint, or TMJ, and then the movements of the TMJ. So first, let's look at the bone structure. And this structure is all throughout the body, but of course we focus on the bones that are in the head and neck. So I like to think of bones like Kit Kats, and the Kit Kat has an outer hard shell, which is the chocolate part, and a fur bone that is the compact or the cortical bone, so the outer hard shell. And then inside is a light spongy wafer, and this is the cancellous bone. And then surrounding the whole thing is a protective wrapper. So if you think about a Kit Kat, you've got a protective wrapper, chocolate, and then a wafer. And so for our bones, we have periosteum, which is the protective wrapper, cortical bone, which is the hard outside, and then cancellous bone, which is the inside spongy bone. The periosteum is necessary for bone growth and repair. So the bone needs to have this outer protective wrapper to be able to grow and live well. So what this looks like on X-ray is the way that we're going to see it most often. And so if you look here, the arrows in this picture, seems like you can't see my mouse, which is odd. So the arrows in this picture are pointing to the cortical bone. And if you look at that, that shows up as really white. And it shows up as white because it is very hard and dense. So that is the outer covering. And then if you look around the roots of the teeth, you can see some of these little spider web looking things. And that is the spongy bone on the inside. Periosteum will not be visible on an X-ray. And there's some cancellous bone or trabecular bone at the arrow, just to close up that a little bit. So you can't see cortical bone on this slide. Okay, and what is the real reason that skulls are scary? Because there are too many bones to identify. Just kidding. That's my idea of humor, because now I'm going to really wow you with the bones of the head and neck. All right, so there is a link here of a great site to search, some learning tools that go on there, games that you can play. So if you're interested, you can do that. So there are 8 bones of the cranium and 14 bones of the face. The cranium is what protects the brain. So there are 8 bones that protect the brain, and then 14 bones that make up our face. So we're going to start with the cranial bones, and this shows the occipital, parietal, and temporal bones. So occipital is the very back of your head, and I find sometimes that this is actually, it's useful to make the motions. As you say the bones, you might feel a little funny, but we're all friends here. So occipital in the back, temporal on the sides, parietal on the top sides. So there are 2 parietal bones, one right and one left. 2 temporal bones on the side, one right and one left, and only 1 occipital bone. And this makes up the main part of your brain case, or your skull, as we're used to calling it. And all of these bones are connected by sutures, which start out really soft when we are infants, and then ossify and harden as our brain continues its growth. So how does your brain grow without breaking a bone? Well, those sutures or stitches that hold our brain together are movable when we're very young. So as the brain grows, which it does a little bit after we're born, the bones will keep up with it. The frontal bone is the last piece of major bone in the front. So the frontal bone is your forehead. That's the frontal there. And then behind your eyes, separating your brain from your mouth, nose, and eyes, are the sphenoid bone and the ethmoid bone. So the sphenoid is basically behind the eyes, and it is bat-shaped. And so the bat shape to the sphenoid bone leads people to call it the backbone sometimes. So the sphenoid bone is bat-shaped and behind the eyes. And then behind the nose is the ethmoid. And I always think the ethmoid looks like Maleficent. If you've seen the movie, you know what I mean. So that is the bone that separates our nose from our brain. But hopefully you can see that both of these bones are really thin. So behind the eyes, behind the nose, there's not a lot keeping that from communicating with our brain. And then we look at the facial bones. So the first two facial bones that are important to us are the maxillary bones, and there are two of them, one right and one left, and the mandible, which is the lower jaw. The parts of these bones that make up the jaws, where the teeth live or the teeth are stuck into, is called alveolar. So the alveolar bone is where the teeth live. We're going to get into those bones a little bit, get more intimate with them shortly. Continuing on with the bones of the face, we have the zygomatic bones, which are also called malar, and these are your cheekbones. And they make up the sides of the eyes as well. So sides of the eyes and cheekbones are your zygomatics. The vomer, which is the base of what divides your nose into right and left halves. So the vomer is the very base of that, and the rest of it is cartilage that keeps our right and left halves of nose separated. And then we have the palatine bones, which are very far back, and they actually go up and down. So most of us think of our palate as being flat, horizontal, and that's true, but it's the maxillary bone that makes that up. It is the palatine bones that go straight up and down towards the nose. So as you can see in cross-section there. And then we have the inferior conchae, which are scroll-shaped bones inside of the nose. So lots to know about the different parts of the head and neck. Lots of little bones in there. And there's the puzzle together. And so this is a really good way of testing yourself. And so I've got unlabeled so that you can go through and see which ones you can get and which ones you can't. I gotta just leave myself a note to do it. I'm gonna be posting a coloring book on Evolve. So for those of you who like adult coloring, start with a skull. So I'm going to post that, and you can print it off at home if you have a chance to. Maybe the Adult Ed Center can print it out for you if you don't have a chance, if you're unable to print, and you can color that, which is a great way to learn as well. Okay, so I've got some arrows here onto some different bones, and see what you're thinking as the answers come up. So the first one looks like the side of the eye and the cheek to me, and that is the zygomatic. And there's another blank for you to play with. I have in the past asked people to make them out of clay and fruit. So if you're really artistic and you want to carve, go ahead, make a skull out of a watermelon. So let's look at the maxilla in a little bit more detail. So remember, the maxilla is the upper jaw. And so the maxilla being the upper jaw, we call the teeth on the upper, we call them maxillary because they are in the upper jaw. And there are two landmarks that are most important for us to know because they will be on the RHS. And those two landmarks on the maxilla are the hamulus and the maxillary tuberosity. As we get into, when we start to learn more about our anatomy of x-rays, I'm going to point those out to you a million times. But what I want you to see right now, take your tongue and put it up behind your very last molar. Kind of make friends with the rounded part behind your last molar. Can you feel that there? So not a place your tongue goes to that often unless you've got something stuck. But that is your maxillary tuberosity. So a tuberosity is a rounded end of the bone. And this rounded end is our maxillary tuberosity. And then just behind that is a hook-shaped projection called the hamulus. And so those two things we're going to look for on x-ray when we start to study our x-rays. Okay, the mandible is the lower jaw. And so the teeth in the lower jaw are called mandibular because they are part of that lower jaw. And the mandible has many more landmarks than the maxilla does for us to play with. And a couple of those, the first two that I will have you look at, are the coronoid process and the condyle. So if you can find those on the picture, they're the top spikes or the top ends of this bone. And the condyle is what joins with your skull. So if you take your hands and you put two fingers in front of your ears and open your mouth really wide, what you can feel, besides a little bit of pain for most of us, is the coronoid process of your mandible dropping downward. And then the condyle is what is connected to your skull. And so the condyle is the part of the mandible that makes up the jaw joint. And so I'm sure you've heard someone say, "Oh, I have TMJ." And to that I say, yes, you have two of them. All right. So you may have something wrong with your TMJ, which is a different thing. But the condyle is the part of that jaw joint that makes up the one that tends to give people a run for their money sometimes. Another landmark to point out is the mental protuberance, which is a really fancy way of saying chin. So why do they have to make it so complicated? I don't know. But so what's the mental protuberance? It is the chin. And that little bump there that is in blue, you should be able to pick up. The mandible is horseshoe-shaped from above. This fact also plays in later when we study radiology. Okay, so temporomandibular joint. You have two of them on each side of your head where the temporal bone joins the mandible. And so we must, as dental professionals, have an understanding of the anatomy of the TMJ, normal joint movements, and possible disorders of the joint. So a joint is a junction between two or more bones. And the function of the TMJ is that we are able to speak and chew. Patients often come in with issues with one or both of their TMJs. And so to be able to sort of speak well about it and identify it to the doctor, what the patient is saying or complaining about, is part of what our job is as the dental assistant. So we don't have to diagnose it, but we do have to know a little bit about it so that we can sympathize with our patient and speak to the dentist correctly. So here in this picture you see the temporal bone, the mandible, and the location of the place where the two meet, or the temporomandibular joint. And it has two motions. The first motion is a hinge motion. So if you've ever opened a door, you know what a hinge motion is. And the first motion of the jaw joint is almost, gravity takes it. So it's easy to drop your jaw open. It's the second motion that tends to cause people issues. And this is the glide motion. And the glide motion is like a porch swing. So even though we are able to move our jaw in many different ways, there are only two motions going on. And the way that we have the jaw move in different ways has to do with muscles pulling either separately or together. So I don't know, I don't think the next slide has, no it doesn't. Okay, I'm just going to go back to that for a second. So the jaw joint is protected by a capsule of sort of like a bubble, like a cushion. So these bones, the part of the mandible, the condyle of the mandible, and the temporal bone are safely encapsulated inside of a bubble. And that bubble serves to protect it if we get hit in the side of the face. All right, so, something like if you've ever been whacked with a ball, you know what I mean. I can think of a time when I was on a go-kart when I got whacked in the side of the face. So these things do happen to it, and that cushion protects it. But what tends to give patients the most trouble is that between the temporal bone and the mandible, there is a disc, just like you have a disc in your knee or a disc in your back. And that disc keeps those bones from grinding together. If the disc breaks down, or if the jaw joint maybe clicks over the disc or moves over the disc, that's when we begin to hear noises or feel pain in our jaw joint. And so how do we palpate this? Well, the same way that I just had you do, by putting your hands up to your ears just before it and having the patient open wide and then close again. Yeah, I said that already. I do that. I get all excited about it. And this too, the meniscus is another way to say disc in between the two of them. So the disorders and movements of the temporomandibular joint, that hinge and glide action, the glide is the second phase, the hinge is the first phase. When the muscles move separately of each other is how we can get our jaw to move backward and forwards from side to side. All right. So patients will come in with disorders of the temporomandibular joint, and their complaints are usually pain, sometimes swelling, and docs may recommend a number of different things for this. One of the things to realize is that jaw joint pain typically needs more than one specialist to address it. So a dentist might be involved, an orthodontist might be involved, even a psychiatrist or psychologist might be involved. Because one of the things that we do as people is we internalize our stress right here in this jaw joint. So the patient may need like a muscle relaxer or an anti-stress medication, an antidepressant, to help that out. So there are many different things that can go on with this. So the next topic to look at are the paranasal sinuses. Paranasal sinuses, we mostly drop the paranasal when we talk about it. We usually just say the sinuses. And the sinuses have functions other than irritating you in the wintertime. They provide mucus, they make the bones of the skull lighter, and they also help to produce sound. The names of the paranasal sinuses are named for the bones that they are located in. So we have frontal sinuses, ethmoid sinuses, and maxillary sinuses. And of course they live in the bones by the same name. Frontal sinuses, you'll feel if you have a headache sometimes. Ethmoid sinuses will give you pain and pressure in the nose and behind the eyes. And maxillary sinuses can often masquerade as a toothache. So these sinuses become important to us in dentistry because we see patients sometimes with these sinus infections who think they have tooth infections. And so this just shows you how close that maxillary sinus is to the teeth by aligning what's inside the mouth there. There are lymph nodes throughout the head and neck. Lymph nodes are immune structures that typically are collection places for fluids and cells that might be fighting infection. And so we palpate those. The dentist will examine the nodes of the neck to look for swelling or tenderness. And a swollen lymph node is typically a sign of infection. And so if a node is found, doc's going to look closer there. And sometimes that infection masquerades as cancer. All right, so lymph node palpation is something that is done or should be done at least every 6-month check, if not more often. Okay, and so there's a representation of where the lymph nodes are. They're in green. So if your dentist comes and starts palpating along your jawline and then down along your neck and even around your clavicle, they're not trying to be inappropriate. They are looking for those superficial nodes that can signal something wrong. Okay. We have some openings in our bones that are important to us in dentistry that allow blood and nerves to run through them. So a foramen is an opening in a bone that's like a tunnel, and the vein drives through it. So a vein is a vein, artery, nerve. And if you can see my little cartoon there, there's the Scooby Mobile, and it's coming through the tunnel. So what kind of vein is it? It's a vein, artery, nerve. And this foramen is a hole in the bone where that can pass through. So we have a mental foramen, one on each side, right and left, right near the, say, edges of your chin. All right, so these are about just before the cheek starts, down on the mandible. We have mandibular foramen that are on the inside of the mandible. And so those are important in anesthesia, both of these points. So dentists will be looking for these foramen to get the patient properly anesthetized for their appointment. And then we have an infraorbital foramen, which is just below the eye and right about above the canines. So your eye teeth here should have an infraorbital foramen right above them. And as we talk about foramen, or holes in the bone, we then, of course, have to talk about the nerves because they're part of the vein that goes through them. And so nerves in the head and neck are near and dear to the dentist's heart, and this is because there is always some variation among humans about where nerves are. So we can say where we expect them to be, but every patient is different. And why does the dentist need to know? Because that's what we need to quiet down so that we can get our work done. So in the head and neck, the teeth, tongue, and cheek are innervated or supplied by the trigeminal nerve. The trigeminal nerve is also called cranial nerve number 5. And we say that it is the primary innervation of the oral cavity. The trigeminal nerve divides into maxillary and mandibular branches. So there is a branch of the trigeminal that supplies the upper teeth and a branch of the trigeminal that supplies the lower teeth. And so the key to nerves for the teeth is to know where you're at. So for upper teeth, if you are in the front of the mouth, the nerve is called anterior superior alveolar. Anterior because it is front, superior because it is upper, and alveolar because it is the part of the bone that holds the teeth in. Is everybody with me there for decoding this? If I am on the side of the mouth, I have a middle superior alveolar, middle, upper, bone that holds the teeth in. And if I am in the molar region, or way back on the upper, I have posterior superior alveolar. For the lower teeth, it's a little bit different because of those foramen that we saw. So on the lower, everybody's called inferior alveolar nerve. And then there is a mental nerve, which sends branches to the middle teeth, and an incisive nerve, which sends branches to the front. Okay. So why do we learn about these? The blood supply being artery, capillary, and vein, is because we are constantly, on a daily basis, using anesthesia to numb those nerves and get them to be quiet. So knowing the nerves and blood supply is important because we place different things in the mouth all the time, and we want to be sure we know where they are. Even though we don't give anesthesia, we're assisting it. So we need to know. And we'll talk more about anesthesia in a couple classes. So here's a list of bony landmarks that we need for radiology. And these bony landmarks, this slide in particular, is one that I'm going to show you again and again when we are in radiology, because every single one of these is going to have to be familiar to us by the time we go to take our RHS exam. So, mental foramen, and I'm just going to point them out or sort of generalize, down here on the mandible, one on each side, right here at the edges of the chin. Coronoid process and condyle are the two wings of the mandible that connect to the skull. The lingual foramen and genial tubercle, mylohyoid ridge, those are ones that we will discuss later when we get to radiology. We have the mandibular foramen and canal, maxillary sinus, maxillary tuberosity, so take your tongue and pour it up and back of that last molar to make friends with your tuberosity again. Hamulus, which is the hook shape. Zygoma, or zygomatic, your cheekbones. Median palatine suture, which is the very middle of your palate. Nasal spine, which is a little bony spike right at the start of your nose. And incisive foramen. The incisive foramen is right behind your front teeth. It's the one that you burn when you bite into a hot piece of pizza. I bet you've done it. Now everyone's hungry. Yeah, me too. Okay. And so I'm just going to superimpose a dental radiograph over these. And what I have outlined here are the maxillary tuberosity and the maxillary sinus. Here we have an image of the mental foramen, image of the mandibular canal, and a couple different other landmarks that we will get more familiar with. We have the coronoid process, the hamulus, and the incisive foramen. All of these things we can see on X-ray. Note that the bones and the teeth appear white, while air spaces or holes appear black. And everybody always wants to know, what are those white circles, right? Those really bright white, those are silver fillings. We have the zygomatic process, so we can actually see the cheekbone on a dental x-ray. We have the maxillary sinus, and we have the inverted Y, where the maxillary sinus and the nasal cavity come together. A little bit about muscles. So the muscles have different functions as they do in most of our, in our body. And I have matched some of the major ones that you're going to want to know for your test, wink, wink, nudge, nudge, with emojis, because I thought it was fun. So your buccinator muscle is your sucking muscle, or your fish face muscle. The orbicularis oris is for puckering and kissing. Zygomatic major raises the corner of the mouth to smile. The external pterygoid opens the jaw, so it is not an elevator. It does not close it. It is an opener. And the masseter and temporal muscles are jaw elevators or closers. And we are almost there with the anatomy. So there are a bunch of landmarks on the face that we use regularly to refer to different areas. And most of these we know because we're going to use them to line up a patient for an x-ray, or because we need to have a landmark because we can't see some of the patient's face, and we need to be able to use the landmarks that we can see. So, outer canthus is the outside of your eyes. Inner canthus is the part of the eye near the nose. And the canthus gives our eye its shape. Alae, or ala for single, is the nostril, the outside of the nostril. The philtrum runs from under the nose to the midline of the lower lip. Nice little depression there. Just gonna
They did that.
Funny. All right. Tragus, some people get this pierced. The tragus is the little flap of cartilage right in front of your ear. Nasion is the point right between your nose. Glabella is just, I should say, nasion is between your eyebrows, basically. Glabella is just above your eyebrows. The root of your nose, or bridge, is just below nasion. Septum is inside your nose. I'm not going to point to that. Anterior nares is the opening to the nose. The mental protuberance is, remember, the fancy way to say chin. The angle of the mandible is here on the corner. So it's the side of our face, just below the ear. And then zygomatic arch is your cheekbones. So some of these have names that are similar to the bones that we've already discussed, and others are new names. So you can come back to this slide to 1, 2, 3, 4 through 13 yourself on this. And then 45 minutes later, we're into the inside of the mouth, right? So it takes a while to get all of the names of these things down and to not feel overwhelmed by them. So this might be the one test that you feel like you need more time on, that you need to, spend some more time on. And I would encourage you to use as many of the resources as possible so that you hear this in different ways, so that it stays with you. So the oral cavity is divided into the vestibule and the oral cavity proper. The vestibule is the space between the cheeks and lips and the teeth. So if you close your teeth together, all of this stuff here is vestibule. So once you open your teeth, then you're in the oral cavity proper. And the oral cavity proper has the tongue and the palate. Inside of the mouth is lined with mucosa. And mucosa is what protects the inside of our mouth and what keeps it lubricated and helps us to speak and helps us to chew. But there are two different types. So the lining mucosa is thin and easily injured. And if you've ever bitten your cheek while eating, you know what I mean. So the cheeks, the lips, the floor of the mouth, the soft palate, which is behind the hard palate, is as far back as you'd want to reach your finger, and under the tongue are all very thin areas that are easily injured. I know, like, sometimes I'll get a tortilla chip down under my tongue, ouch, right? So those areas are not for chewing, typically. The masticatory mucosa is thick and tough. And we have this, our gums are masticatory mucosa, the hard palate, or the roof of your mouth, the top of your tongue. These are designed for chewing, and they stand up to wear much better. So there are different areas of the gingiva, and you can see that there's going to be a color change between the mucosa, or the alveolar mucosa, that lining mucosa of the lips, and then the attached gingiva, or the masticatory mucosa. So lining mucosa is typically redder, and masticatory mucosa is typically pinker, because of the functions that it has. And then we have the palatal rugae, which are those ridges on your palate. And then right behind your front teeth, we have the incisive papilla. Palate is the roof of the mouth, and uvula is the hangy-bally thing in the back of the mouth, along with the palatine tonsils, if you still have them. Salivary glands are the last little bit of anatomy that we look at here. We have 3 pairs of salivary glands, 3 on each side, so there are 6 in total. We have Wharton's duct, which is under the tongue, and is sometimes called Old Faithful. You may know someone who is able to make Wharton's duct squirt on command. So I know in elementary school, all the kids used to try and do this, see if you can shoot saliva at your best friend. It was a great pastime, right? And then we have Stenson's duct, which is up here at the parotid salivary gland. And that is the one when you eat a Sour Patch Kid that really goes crazy. So it's the one right up here in your cheeks. So the parotid gland is one of the pairs of salivary glands, one on each side. The sublingual gland and the submandibular gland. So we have got 2 down underneath the mandible, or under the tongue, and then 1 up in the cheeks for the upper jaw. Saliva is protective, and helps with speaking and digestion. So the alveolar bone, which we've referred to a couple times tonight, is the bone that holds the teeth in. And part of the alveolar bone that we talk about a lot is called the alveolar crest. This is the highest point of bone in between the teeth. The higher your crest is, the healthier your mouth is. So this is a measure of health in the mouth to look at the alveolar crest. So everywhere you see the arrow, it's pointing to alveolar crest. And I've got it outlined in blue there because I want you to think of a wave. So the crest of the wave is the top of it. Okay, last thought, gag reflex. The gag reflex is something, oh, please don't shut down on me. Why is it going to shut down? Oh boy. Hold on a second, guys. Is it this that's going to shut down? Oh.
Yeah, it's not a computer. I bet it's the...
It's the Tandberg, yeah. Look at this thing. Why will it shut down? Do you mind getting up and just touching the screen? Just tap it. You didn't know you were going to work. Thank you. Yeah. Fixed it. Oh, it's always an adventure. Okay, so the gag reflex, impressions, suctioning, and radiographs are when we are likely to see this reflex from our patients. And that is because we are touching, or something is touching, the palatine tonsil, the back of the tongue, the posterior 2/3 of the tongue, the uvula, and the posterior pillars of the throat. So some things to help to coach your patient through this are to remember, number one, it is not the patient's fault. This is an involuntary reaction. And if you've ever heard someone gag, especially a man, they make the scariest noise I have ever heard in my life. You'll jump a mile when you hear someone do this. And it doesn't matter whether they're your patient or they're patient 3 doors down. You're going to hear this, and it's going to make you start. The best thing I can say is the calmer you are, the calmer your patient will be, the less likely they will be to freak out. So tell the patient, keep your eyes open, breathe through your nose, compress your left thumb, something about a pressure point there, and find a point on the far wall and keep those eyes on it, focus on it. This is the one time when you're an assistant that you've got to be a cheerleader. So I have made every silly face in the book to keep my patients' eyes open and cheered them on through an impression that I needed to leave in their mouth or a radiograph I needed them to hold in so that I could press the button long enough. So this is the one time when you really do your cheering here. All right. And now that I have absolutely talked your ear off, do you have any questions? So besides how on earth am I ever going to remember all of this stuff, do you have any questions for me on chapter 3? Yeah, that's usually what chapter 3 does to everybody. Dead silence. All right. So one thing to know is that I have a short review video on chapter 3 that I will post that kind of like says it again in another way. So that'll be up too. And we are going to move on to chapter 4. As long as everybody's happy. Cheryl, can you see us? Oh, yay. She fixed it, huh? Good. That's great. In the middle of it, I was like, this is a terrible time to not be able to see. Anatomy is tough. So I know that your brains are fried. I don't know what time. Oh, good. I'm doing well tonight. That's great. But I want you to sort of take a deep breath, put all the anatomy behind you, and come with me to the land of teeth. So chapter 4 is dental anatomy. And for those of you, who are loving dentistry already, this is our language, dental anatomy, this chapter. This is the language we speak. So if anatomy intimidates you, realize that it is a step to get to where you want to be. So I love anatomy, but I know not everybody does. And so the dental anatomy, though, is really what we use on a daily basis in the dental office. So this is the stuff that will be your your test for whether you're grasping. So the dental anatomy, we've got a couple objectives. Again, we start with pronouncing, defining, spelling the key terms. We want to learn the anatomic parts of the tooth, explain the tissues of the tooth, and then we'll get into the teeth themselves and how we talk about them, the terminology that we use for talking about teeth. All right, so this is the language of dentistry, as I said. First, we're going to look at how teeth form. And this is embryology, and I am hoping that this will allow us to watch it. Ooh. It's not coming up, not there, though, is it?
What's amazing about tooth development is how early it starts.
Hold on, I know you can't see it yet. There's my nose. There it is.
What's amazing about tooth development?
Shush. Why are we frozen? Wait. That happened.
Did it switch it again?
Yep.
That's weird.
Yeah.
It's me not to fix it.
Yeah. Thank goodness.
Is how early it starts.
Okay.
This embryo is only 6 weeks old, and yet the epithelium over its mandible is already thickening in preparation for what's about to happen. As it grows thicker, the epithelium creates an island of cells, which is the origin of the new tooth. This is the dental lamina, and its remarkable potential is starting to unfold. As we get closer, we can see other key players in the formation of our dentition. Meckel's cartilage provides support for the developing tissues, and the blood vessels that help shape the embryonic teeth are present. By now, the lamina has grown into a bud. The epithelial cells haven't changed much, but as the bud grows, it starts to bend into a dome in response to pressure from the blood vessels, and the mesenchymal cells underneath condense. At this point, we can already identify the cells that will form the tissues of the mature tooth. The enamel organ is made of cells from the epithelial cap, and it will generate the enamel of the tooth. The condensed mesenchymal cells will form the dentin and the pulp, and they are called the dental papilla. The dental follicle will develop from the remaining condensed mesenchyme. And all of these cells together are known as the tooth germ. So far, we've seen the bud and cap stage of tooth development. The third, and most dramatic, is the bell stage. As the tooth germ begins to grow, the cells differentiate. The stellate reticulum is now obvious. Made up of star-shaped cells pushed apart by fluid pressure, it separates the inner and outer enamel epithelium. Just visible is a flattened area of cells called the stratum intermedium. We can also see the juncture where the inner and outer enamel epithelium meet. This cervical loop is important in tooth formation, as we'll discover soon. By the time the tooth bud pinches off from the dental lamina at the end of the bell stage, the inner enamel epithelium has folded to form the shape of the future crown. With a scaffold to work on, the masons of the tooth world go to work. The cells of the inner epithelium have elongated into ameloblasts, and the neighboring cells in the dental papilla respond by changing into odontoblasts. Now they move toward the center of the papilla, leaving a thin tube of cytoplasm and a layer of dentin. And now, the ameloblasts start to move, leaving behind the hardest tissue of all, enamel. The resulting rock-hard crown of enamel and dentin is a miraculous feat of cellular engineering, but the engineers haven't finished yet. An extension of the cervical loop forms as a collar called Hertwig's epithelial root sheath that causes other odontoblasts to start forming the dentin of the root. At the same time, the whole tooth starts to move like a biological rocket taking off, and a perfectly formed deciduous incisor is delivered into the oral cavity. Its new owner, of course, is delighted.
I love the end of that. So that is not in your textbook, the part about tooth development. But I always think that it's a great idea, button, to look at that and just realize that tooth development begins at 5 to 6 weeks in utero. And at 17 weeks, that's for the baby teeth. And at 17 weeks in utero, we begin to form our permanent teeth. So it's really early in the in the stages of human development that teeth become part of us. Okay. So the first molar at 17 weeks of development, second molar 6 months of age, third molar 5 years of age, and most of this is just interest rather than exam material. And then to help us understand the whole picture, the mandibular teeth form first, and they begin in the anterior, and they erupt first as well. And so when a baby's getting their teeth, typically the first to come in are the lower anteriors. And it kind of is like a pinball machine from there. So it goes bottom to top, to bottom to top, to bottom to top, and back and forth until the child has all 20 of their baby teeth. And then at around 6 years of age or so, 5 or 6, they begin to loosen, and the permanent teeth make their way in. And because of the way that teeth form, the permanent teeth come up lingual to or behind those primary teeth. And so this tends to drive patients into the dental offices, moms saying, "What's wrong? Why are those teeth coming in so close to the tongue? Why are they behind?" Because we think, oh, they're going to be bigger teeth, they should be in front of. But it actually has a lot to do with the way the jaw grows. So where should teeth be coming in when they come into the mouth? They're actually going to be coming in behind the baby teeth. All right, so why is this information useful? For educating our pregnant patients, for knowing that we never judge a patient because some teeth are missing at birth. So patients may have missing teeth, and sometimes and this is not a blanket statement, but sometimes the temptation is to say, oh, they must not have taken care of their teeth, that's why they don't have them. But we need to realize that because development starts so early, that stains and deformities and missing teeth can happen before the child is even born. A high fever as an infant or a child can affect the permanent molars, and permanent molars are designed to last us throughout our lives. So something that happens very early can, cause an issue for the development of the child and then in the adulthood as well. So the other thing to note is that the way teeth form causes pits and fissures in the biting surface of the molars. Decay is very common here because a toothbrush will not fit into those pits and fissures. So a child has no way of cleaning them. And I can remember as a child being scolded for having cavities because it must have been something I did. Imagine my delight when I learned that I likely wasn't at fault and got to throw it back at my parents. Ha, see? So everything's your parents' fault, you know that, right? And if you're a parent, you know it's your fault. So knowing a little bit about how teeth form or the embryology of teeth can help us to be more empathetic or to feel more of what the patient is going through. Why does this want to play with me? Stop playing with me. Well, it keeps it interesting, doesn't it? Slideshow. So you guys can see it, but I can't. There we go. Okay. All right. So now let's get to the tooth. All right. So the tooth is divided into two parts. It has a crown and a root. And it has 4 layers. So enamel is the outer layer that covers the crown. Dentin is the inside layer that is in both the crown and the root. Cementum is the layer that covers the root. And the dental pulp is the inside. We're going to get into this a little more here. So here are our 4 layers. We have enamel, dentin, pulp, and cementum. And then we have the crown and the root. So enamel covers the crown. Notice the color coding. Dentin is throughout the whole tooth, crown and root. So follow it with your eyes there. Follow that yellow layer all the way through to the crown and the root. Notice how the enamel stops at the root. Cementum is the layer that covers only the root surface. And then the dental pulp is the nerve and blood supply for the tooth. It's the living part of the tooth. And it sends its fingers, that nerve and blood supply, into the dentin. Nerves more than the blood supply. In green, we see the periodontium. The periodontium is the support system for the tooth. And so the periodontium is what holds the tooth into the alveolar bone. So your teeth are held firmly in the bone by fibers that connect cementum to bone. And those fibers are called periodontal ligament. So the periodontal ligament connects the root of the tooth by the cementum to the bone. The apex is the tip of the root. So the apex of a tooth is right where the root ends. And just another way of looking at it, some different colors without all the lines and confusing names, right? Okay. So each tooth consists of a crown and 1 or more roots. The size and shape of the crown vary, and the size and the number of the roots vary according to the type of tooth. The part of the tooth that is covered with enamel is called the anatomic crown. But the part of the tooth that we can see in the mouth is called the clinical crown. And the clinical crown may include enamel and root surface. So if someone has, a way of saying that someone is older is to say that they are long in the tooth. And what that means is that we can see part of their roots, that we see more of their tooth. And we call that the clinical crown, the part we can see. The anatomic crown is only the part that's covered with enamel. The root is the part of the tooth that is normally embedded in the bone. And the cervix is where the crown and the root meet. Cervix is just a way to say narrowing. Okay. And so there are different numbers of roots depending on the type of tooth. Either 1, 2, or 3 roots may be present. The word bifurcation says that there are 2 roots. It means where the 2 roots split. The word trifurcation means that there are 3 roots. And it's where those roots divide or split into 3. Here's a better picture of the anatomic versus clinical crowns. So you can see when someone says they're long in the tooth, it's because we've got that extended part of the tooth that's visible. So that's root that we can see there. And that is dentin that we're looking at. Notice how enamel is much whiter than dentin is. And dentin has a yellow color to it. Enamel is either white or gray or see-through. And the dentin tends to be the yellow part. Enamel is made up of a million different calcified prisms that reflect the light, they are also called enamel rods. And they tend to be perpendicular to the surface of the tooth, meaning that if the tooth is like this, the rod is like that. So it's at a different angle. It's at 90 degrees with the tooth. The dentin is covered by enamel on the crown and by cementum on the root, and it is yellow and tends to darken as we get older. Dentin is harder than bone and cementum, but is not as hard as enamel. So enamel is the hardest substance in the body, and then dentin is next, and then bone, and then cementum. Dentin is made up of little tubes, microscopic tubules, called dentinal tubules. And inside these dentinal tubules is a nerve fiber. And I have a lovely visual of this. So if you look at the left side of the picture, we can see the enamel and then the exposed dentin of a tooth. And the exposed dentin has all these microscopic little holes in it, and those little holes, each one of them, contains a nerve fiber. And so if you have sensitive teeth, if cold water or brushing tends to make your teeth feel uncomfortable, this is because in a millimeter of dentin, you've got about 30,000 of these nerve fibers exposed. So if you ever take a drink of something cold, and it could be a cavity, but it may just be exposed dentin. And as we get older, our gums tend to pull away a little bit and recede on the tooth. And that's when we start to feel all those wonderful things. So the pulp is the nerve of the tooth, and it is the chamber is where the nerve lives, the pulp chamber. The part of the pulp that's in the crown is called coronal pulp, and the part of the pulp that's in the root is called radicular pulp. And if you think all these names are ridiculous, wait till we get to the rest of them. No, I'm just kidding. All right, so this just gives you an idea of what the pulp tends to look like. So in a tooth with two roots, we typically have two horns inside of the tooth, and then two root pulps as well. So the pulp is blue in this picture. And then the pulp exits, or the nerve exits the tooth at the apical foramen. So in anatomy, when we were talking about the nerve supply to the teeth, we were talking about if we were working on a top tooth, the nerve that we need here is called the anterior superior alveolar, because it's front, upper, and for the teeth. Well, that little nerve will send a piece right into the apical foramen of the tooth. And so what the dentist attempts to do when they are anesthetizing your teeth is find that nerve before it goes into the tooth and get it to be quiet so that they can get the work done. Okay. And then this is our last part of the dental anatomy, and probably the most important part, but this takes time. So I told you last week that my training as a dental assistant was here's a tray, memorize it. And I had to learn the names of the teeth, the numbers of the teeth, the functions, the locations, all of that on the job, which was harder than it seemed. So we are going to look at the teeth. So there are 4 types of teeth in the permanent dentition. There are incisors, canines, premolars, and molars. And these 4 types of teeth all have different functions, and they have set locations in the jaw. So you have incisors, canines, premolars, and molars on the upper on the right side and on the upper on the left side. You have the same on the lower on the right side and the lower on the left. In the primary dentition, for children before the age of 6, there are only 3 tooth types. So children are missing premolars. They don't have the premolars. And this is because their mouths are smaller and they don't need those premolars quite yet. So children have incisors, canines, and molars. And we call the dentition at that time of life primary. Okay, so now let's look at the surfaces of the teeth. So the side of the tooth that is closest to the lip, find that in your own mouth or on the picture. But notice which is closest. I know you can't see. Let me get a pointer. That'll help. Technology. Okay. So this is the side of the tooth that is closest to the lip. Where does your lip end? It ends, by definition, it ends right about the canine tooth. So only canines and incisors have a side of the tooth that is closest to the lip. Premolars and molars, that same side of the tooth is closest to the cheek. So it's no longer lip there, it's cheek once it passes the canine. So we're looking at that there and that there. And then we have the side of the tooth that is closest to the tongue. And that would be the back side of the tooth, or the side that your tongue would touch first. And that is in purple. We have the side of the tooth that is closest to the middle of the face. Okay, so the middle of the face is going to be right between your incisors in the front, your central incisors. And this side of that one tooth is the closest to the middle of the face. That side of the other tooth is the closest to the middle of the face. So this is a description that we use on each tooth. We say that each tooth has a side that is closest to the middle of the face, and each tooth has a side that is furthest away from the middle of the face. And that's in blue as we're adding it in. As we said, we have the side of the tooth that touches the cheek. And then we have the biting surface of the tooth. And for front teeth, this is the very edge. And for back teeth, it's the top. And all of these fancy little spots have names, all right? So labial is the side of the tooth that is closest to the lips. Very rarely do we use this terminology. Labial is what is in your text, and so I kept it that way, but we also say facial for this rather than labial. So facial is kind of the updated way to say it, and that's because labial always makes people snicker. Right? Thinking about a different part of the anatomy and not the mouth. Okay. Lingual is the term for the side of the tooth that is closest to the tongue. Mesial is the side of the tooth that is closest to the middle of the face, or the midline. So all those pink dots are mesial. Distal is the name for the side of the tooth that is furthest from the middle of the face, or most distant from the middle. And remember, this is per tooth. So all those blue dots are distal, but every tooth has a distal surface. Buccal is the name for the surface closest to the cheek. Occlusal is the name for a posterior tooth on the biting surface. And incisal is the name for an anterior tooth on the edge, or its biting surface. Okay. And so here it is again, and I'm not going to spend the time to go through it, but it's color-coded, and you can keep going through it. Okay, So we have two arches, maxillary and mandibular arches. We have four quadrants. We have the maxillary upper right and upper left. We have mandibular lower right and lower left. And there they are divided out with those red lines in between them. It is typical for us to use abbreviations for these quadrants. So we say UR and UL. What are we talking about there? Upper right, upper left. Or we could say LL and LR, lower left and lower right. And usually those abbreviations are used in writing more than they are used verbally. Okay, so we have two arches, four quadrants, and 8 teeth in each quadrant. So the maxillary upper right has 8 teeth, and they are teeth numbered 1 through 8. The maxillary upper left has 8 teeth, and they are numbered 9 through 16. The lower left has 8 teeth, numbered 17 through 21. And the lower right has 8 teeth, numbered 25 through 32. So, how many teeth are there in total? There are 16 per arch. So 1 through 16 are maxillary teeth. 17 through 32 are mandibular teeth. And that gives us a total of 32 teeth in the mouth. One of the ways that I encourage you to get oriented to the numbering system is to memorize your canines. So, your canine teeth, you have 1 canine in each arch. Your upper right canine is tooth number 6. Your upper left canine is tooth number 11. Your lower left canine is tooth number 22, and your lower right canine is tooth number 27. And if you say these, 6, 11, 22, 27, it's kind of like a chant. It rhymes a little bit. And if you know where number 6 is, you can count to find the rest of the teeth in that arch or in that quadrant, whatever's closer. So if I say, where's tooth number 8, and you know 6, being that it's the canine in the longest and the pointiest, you're going to be able to tell me that number 8 is in the front. And this will help you to get oriented because it gets confusing. Because it looks great when someone's got 32 teeth, but when they start missing them, you have to count the missing ones too. So we have 2 anatomical locations for the teeth. We have anterior teeth and posterior teeth. Anterior are number 6 through number 11. And number 22 through 27. See why I say memorize your canines? And then posterior teeth, 1 through 5, 12 through 16, 17 through 21, and 28 through 32. This describes both their function and their location when we say anterior and posterior. So our 4 teeth types again: incisor, canine, premolar, molar. And I've got them bracketed off here for you in 2 different quadrants. So how many molars do we have? In 1 quadrant, we have 3 molars. In 1 quadrant, we have 2 premolars, 1 canine, and 2 incisors. And this repeats itself in each quadrant. So remember when we first started talking about anatomy, we talked about how right and left are mirror images of each other. Same thing in the mouth. So which ones of these are anterior? And you can match the colors and you'll come up with the fact that both the blue and the orange are inside the anterior green circle. And which ones are posterior? The red and the black are inside the purple posterior circle. So our anterior teeth are incisors and canines, and our posterior teeth are premolars and molars. And then the positions of the teeth in the arch, we have two incisors. The first incisors are central incisors because they are in the center. And then the second ones are lateral incisors because they are to the side. Then we have the single canine. And then the next tooth you come to, whether you're on the top or on the bottom, is your first premolar. So we're counting it from the midline when we say first. So we have first premolar, second premolar, first molar, second molar, third molar. Another way to say third molar, wisdom tooth, right? If you know anyone or if you yourself has had the pleasure of having them extracted, no one knows why they're called wisdom. All right. They call them that because they typically come in when they think you're smart enough, 18 to 25. For those of us who've made it past that age, you know you're not smart at that age. All right, so when you're counting these, when you say first and second, you always want to start, the one closest to the midline is your first. Something to note, the third molar is tooth number 1. The first molar is tooth number 3. Let that rattle around in your brain for a little while. So upper molars have 3 roots and lower molars have 2 roots. This is because upper molars need to grab on against gravity, so they've got an extra hook to help hold them up in the jaw. Lower molars only have 2 roots because they spread out like trees. They're firmly planted against gravity. Incisors are there to help us cut food and shovel it towards the back.
Can I ask you a question?
Yes.
Just with the wisdom teeth, and so if you get them removed, do you start at 2 if they're considered number 1?
Yep, but what we would say for a patient who's had them removed, we say number 1 is missing.
Okay.
So we still talk about it even though it's not there.
Okay.
Yep, good question.
Okay, thanks.
You're welcome. So incisors cut food, shovel it to the back. Canines tear, which is why they're called canines, like wolves and dogs. Premolars are good for holding and beginning the grinding process, and molars are the grinders. So their teeth, the teeth, their functions are suited to their shapes. So this is common of all phases of anatomy. In physiology, is that the function is going to mirror the structure. Okay, and then again there is this roundup to match the colors. I'm not going to torture you with it again. Trust me, I know how much fun this particular lecture is because it's long and there's a lot of material. So without the colors, give yourself a try to try and find mesial distal, facial or buccal, lingual, occlusal, or incisal, depending on who you are, teeth. And there is a nice little infographic here. I'm not going to click on it because it's going to screw up our presentation, but there's an infographic there that kind of lumps all of that into one little feature. You can click on that in presentation mode and it will take you there. And let's look at this, how we look at this typically. So it's nice to look at a person, they're 3-dimensional, and we can start to feel the surfaces and things. But typically what we do as dental assistants is either on a computer or on a piece of paper. So the dentist is in the mouth looking at the three-dimensional, and we've got to translate it to this flat surface. So we have another chapter in the book that talks all about how we do that, but I just want to get you used to the fact that this is what dental charting looks like on two-dimensional, on a flat piece of paper. So here is my 16 upper teeth. Here are my 16 lower teeth. Here is my midline. And then you'll notice that it looks like I've got two teeth here, right? But actually what I have is the facial surface and the lingual surface. And then where they meet, I have the incisal surface. And this is true for all of those anterior teeth from number 6 to number 11. If we look at the premolars, you can see I've got a buccal surface that touches my cheek. I've got a biting surface or occlusal. And I've got a lingual surface. And this is true for all the posterior teeth. So getting used to the way that teeth are represented in 2 dimensions, because we need to be able to talk about all those surfaces that we noticed tonight in different ways. Because if a patient has a cavity on the buccal of tooth number 15, I need to be able to find tooth number 15, find the buccal, and then indicate a cavity there. All right? And so just as we were saying about if you've had your wisdom teeth removed, we would say that number 1, number 16, number 17, and number 32 are missing. Right. And that's what it looks like without all my fancy notations on it, a little bit bigger. When we get to this part, you'll be able to print these out and play with them if you choose to. All right, so we've gone over our tooth numbering. Primary teeth are lettered, A through T. So permanent teeth, 1 through 32. Primary teeth, A through T. An easy way to remember your primary teeth is that AJ's on top of KT. I know, it's a little bit risque. But AJ, A through J are the maxillary, and then KT is the mandibular, K through T. Hopefully you're laughing and not making faces at me. If you're thinking about orthodontics, there is the Palmer method that is used for talking about the teeth in orthodontics. And what Palmer does is uses the brackets to indicate a quadrant. So the horizontal bracket means upper or lower. If it's on the top of the horizontal, it's an upper tooth. If it's below it, it's a lower tooth. And then this part of the bracket indicates either midline, and then we say if it's to this side of the midline, so this tooth here is a tooth on the upper left. And it uses the letters A through E for primary teeth, repeated in each quadrant, quadrants shown by the brackets, or 1 through 8 for permanent teeth, quadrants shown by the brackets. There is some practice on this in the textbook. Palmer is typically confusing even when you've got a lot of exercises to play with it. I would encourage you to also go into Evolve and look on the chapter for some exercises with that. The other type of numbering system is called the ISO FDI system, and that's used in Canada more than in the United States, and it's used in Europe, and it's based on a 2-digit system. So every tooth gets a quadrant number and a tooth number. So number 18 is not the same as number 18 in the US. And so that's something to note, is that there are different numbering systems used, and you've got to know which one you're speaking. So in the US, we speak universal, 1 to 32, and A through T. Unless you're in ortho or pedo, and then you've got to speak Palmer. So some highlights, and highlights are typically just some things to sort of pay attention to. So I have gone over all of these. It's always a good idea to read through these. I would read through them before I took the test. Wink, wink, nudge, nudge, if it were me. All right, so I'd go through there. But what I tried to do is just kind of pull out some of the things that you would use more often than not with that. So some things that people have questions about. So dentin is lighter in primary teeth than in permanent teeth and yellows as you get older. So who's going to have whiter teeth? Children, right? And teeth tend to darken as we get older. Genetics plays a role in that as well. And then some things about the inside of the tooth. Embrasures are the spaces that are in between the teeth. That's basically where your floss goes. And then teeth contact each other and are shaped the way they are for a reason. So when you lose a tooth, that can have consequences. And lastly, the eruption of your primary teeth should be complete shortly after 2 years old. Your first permanent molar you get at 6. Your second permanent molar you get at 12. When you have baby teeth and permanent teeth in your mouth, we call this a mixed dentition, which is from about the age of 6 to about the age of 12. Exfoliation is the fancy word for saying losing a primary tooth. I know my dad used to call it tie a piece of floss around the doorknob and slam it. So it all depends on where you come from. And then primary teeth should be replaced by permanent teeth. It should all be done about age 12. And so those are things to just kind of, begin to understand so that you can speak with parents and patients and dentists, and like learning your ABCs, this is going to take some time. So don't expect yourself to be an expert right away. It took me a while. All right. So next week is infection control. Try to read chapter 5 before lecture. There's a lot to do, I understand. So you may not get to reading all of the chapters before lecture next week, but hopefully you will try and get chapters 3 and 4 exams done. So what I'd like you to focus on, chapter 3 exam, chapter 4 exam, and then if you have some time, try and read chapter 5. If you don't have the time to read chapter 5, it's not the end of the world. But I would like you to at least try and get chapter 3 done for exams. I know it's a lot to do. I am fully aware of how much I'm throwing onto you. All right, so questions is what I want to know.
Hey, Kelly.
Okay. Yes.
Is this slideshow going to be posted online?
Yes. So
Okay.
the slideshow will be posted. I'll probably do that before I even go home tonight, so that you can look at the slides if you want to. And then the lecture itself will be posted tomorrow afternoon, give or take. And I would say with all these storms coming in and everything, that's of course if everybody has power and can get it up there. So what the school does is they take the recording of this lecture and they process it and then they put it online. And that usually takes up most of tomorrow. So
We're already feeling a little bit better that the slides are going to be up.
yes, I know.
That's what we're
Yeah.
giggling about. We're like, we're so lost. What's happening?
I so know. Trust me.
Awesome.
It's like what
Thank you.
just killed me. Yeah,
I
know.
But yeah, we're being little kids over here.
That's awesome.
Awesome. Thank you.
Cool.
I love it. All right. Any other questions? Everybody finding everything okay? Really, like, no question is stupid. Don't hesitate to reach out to me. I try and get back to you fast, but I'm not always as, sometimes I'm not sitting on my phone, but I'll get to you. Sarah, what's up?
Where do I find the color book?
Oh, I'll put that on. I have a note to myself to put it on. I'll put it on tonight. It'll be in the week folder. Okay?
Cool.
So it'll
Thank
be
you very much.
Under week 2, you'll be able to see it.
Awesome.
Yeah. Coloring's fun. All right. Anybody else? All right. Go home, friends. Stay safe tomorrow.